think I'm going to give you the best and not arguably the favorite type of operation for this. And the answer is probably not, and I'll show you why. So just way of clarification and to define what we're talking about isthmic. So the classification descriptively was promoted by Newman in 1963, and isthmic is the one that we commonly see at L5S1 with lysis around the pars interarticularis, right? So they were further described, and again, descriptively by many, and we'll see myardines in a moment. But isthmic is the most common listhesis that we'll see in adults. It affects about 5 to 7% of the population, generates sometime around the perinatal time frame, and most commonly affects the pars interarticularis. And it's mostly commonly associated with hypoplastic facets and spina bifida occulta in up to 25% of the patients. Descriptively, we also see it described by myardine, and it relates to the amount of slip on the S1 vertebra. And then really the first one that looked at the spino-pelvic relationship is the lumbosacral kyphosis as described by the slip angle. But really one of the coolest descriptions that classified spondylolisthesis into 6 types was done by the Spinal Deformity Research Group, which looked at a spondylolisthesis and the amount of slip, the slip grade, and then looked at the pelvic incidence, and then looked at the overall sagittal alignment. And this is a group that were led by Hubert Lebel and Rusoli in Europe. And what they did is they came up with 6 different types as far as deformities, and really were the first to show that spondylolisthesis, at least in greater than type 2, is truly a deformity and not just a localized issue. So you can't just look at cone-down view, especially at anything greater than a type 2, and think that you're treating the problem. It's a bigger problem, and I think you need to look at the spinopelvic relationships, and you need to look at an overall spine view. So if I'm faced now today with a grade 2 or more, I usually get a full scoliosis series in AP and lateral because there's more to the story than just a localized view. And I think you'd be irresponsible today just to treat the spondy without looking at the entire spine. So more than a grade 2 spondylolisthesis is a deformity, and you need to understand and address the spinopelvic balance, just as Hubert Lebel and Rusoli and their group told us, and there's 6 different classes. So other imaging studies, they're commonly, I think we all know them, so they're there. So what is the source of pain? I think up until today, we're not sure. Instability is certainly one of them, but does instability cause pain? That's a whole other lecture. Disc degeneration, don't just look at L5S1. There are those who argue, well, look, L5S1 is not loaded. The facets are not loaded when you've got a lytic listhesis. So what is causing the pain? And if you look at a group from Toronto, they looked at L4-5, and they said that L4-5 is more commonly the source of pain than actually L5S1 in the adult group. So I think you got to keep an open mind as to what is the source of pain. All right, non-operative treatments, just to list them here, that's all I have to say about that. Surgical indications in the adult, it's usually the persistent of back and or leg pain. That's the most common indication. The other ones you see there, slip and progression, et cetera, is in the adolescent group. If you see that, a slip in the adult, you've got a more serious problem, such as infection, tumor, or something else that you should look for. They don't progress in adults, usually, okay? All right, so what are the surgical options? When you're dealing with an adult, it's usually a decompression or minimally invasive decompression in a radicular patient, and we could talk about that later, or posterior decompression and fusion, whether you do it from the back, whether you just do fusion or fusion instrumentation or circumferential fusion, and that's basically the surgical options in the adult. So surgical considerations, and this is what I'm interested in, and what we're going to talk about today is the choice of the approach, and that usually has to do with the patient habitus. The global sagittal balance is particularly important, and most important is surgeon experience. Okay, so everything I'm going to talk about, it really is nice because I have the right surgeons. I'm in a level 1 trauma center. I have approach surgeons available to me. But if you don't, and your experience is based elsewhere, you do what you're experienced with, or you refer it out. And then complications and dealing with those complications, especially if you're dealing with the anterior approach, I think you should be experienced in that, and not just the approach, but the complications associated with that. Why, to me, is the anterior column so important and to restore that balance? It's because 80% of the load is applied and transferred through the anterior spine. So to me, it speaks to why I like, if I'm going to operate on alytic listhesis, why it's so important to restore that anterior column, right? And why to address it from an anterior approach, because I think you can most effectively approach it from an anterior approach than through a posterior approach dealing with the anterior column. I've talked about this in my last talk. From an Alif standpoint, you improve the motion segment stiffness significantly more than dealing with a posterolateral fusion. Also, look at this. Most of the lordosis is established at the L4-5 and L5-S1 level. That's where you get most of the lordosis. At these two levels, almost 70%. So that's why it's so important when you're dealing with L4-5 and L5-S1 that you can restore that lordosis. Because if you don't, or you give them kyphosis, then you've got a real problem. And this has been shown in numerous papers that you can restore it most effectively, and you restore the spinal-pelvic relationships most effectively by dealing with L4-5 and L5-S1, and again, most effectively from an anterior approach, as compared to a posterior approach, even dealing with the anterior column. So problems with dealing with in deformity, with fusion to the sacrum, loss of lordosis, significant pseudoarthrosis, significant poor results, because you don't address that lumbosacral lordosis and the spinal-pelvic relationships properly from the posterior approach, and they most significantly leads to additional surgery. So if you do adjunctive anterior column support, especially in a deformity case, you get a lower pseudoarthrosis rate, improved outcomes, and improved spinal-pelvic relationships. What about Alif versus Tlif in establishing those ever-important lordosis? And you could see the improvement of segmental lordosis, regional lordosis, correction of AP lumbar curve of Alif versus a Tlif approach. And you could see at the bottom the pseudoarthrosis rate. Actually, in this study is not as promising, but I can assure you that it is higher with an Alif approach. Here's another series of other papers that shows the superiority of Alif over Tlif in establishing lumbar lordosis, in establishing indirect decompression, and restoring that nerve foraminal height as compared to a Tlif approach. And certainly from a fusion standpoint, we can see that the Alif is superior to the posterior approach in getting us a solid fusion at each of the segments. All right. Two cadaver papers, one from Brazil, one from the US, from Vaccaro's group, that looked at cadaver studies and looked at a Tlif approach and evacuating the disc. And so I used to innocently think, oh man, I'm taking all this disc out. I've got 80% of the disc cleaned out. I've got 90% of the disc cleaned out, right? But these cadaver studies showed, and this is cadaver, and you can get as violent as you want, that only about 30 to 40% of the disc is actually removed. And I can't tell you how many Alifs I've done for failed Tlifs and Plifs. And this is Pierce Nunley, my buddy, and this is a Tlif that he reconstructed on the back table when he salvaged it from the front, and you basically reconstituted the entire disc. So to me, oftentimes, and not in the hands of Steve Glassman or others that are hugely experienced in this operation, but really what you're ending up is a channel discectomy. And then what really is bothersome to me, and this is why I think that Tlif can be deformity forming, right, is because the most ideal location to put that Tlif is in the front, and then lordosing from the back and doing kind of a semi-Smith-Peterson and getting that, restoring that. But for that, you need that Tlif in the front. So I don't care if you've got this fancy expandable Tlif. I don't care what you've got. It doesn't make a difference if you don't have it positioned properly in the front. And that's what it tells. So here is why I have referred back to the anterior approach for me. So pitfalls of the Plif Tlif versus an Alif, DRG is at risk, less graft contact posteriorly, poor end plate preparation, and difficulty in realigning if it's not properly placed. So Tlif can create deformity as opposed to correct the deformity. And again, I'm not talking about the ones that are hugely experienced in this. I do use a Tlif still, but my preference is to go from the front, whether it's an Alif, Olif, Alif, whatever. I think you're better served whenever you can to go in and directly from the front. So literature review of isthmic spondylolisthesis in the adults. This is Wiltsey's seminal paper where all he did was, through a Wiltsey approach, did a fusion, didn't use instrumentation, didn't do a decompression, and resolution of preoperative neurological symptoms in patients. And he basically theorized that by fusing, you decrease the motion, and you get decreased spasm of the hamstrings, and therefore excellent relief of the symptoms. And he showed that, but nothing in improving the spinal-pelvic relationships yet had significant outcomes. Bowman in his outcome, and Bowman didn't use instrumentation, and he did use the posterior approach. He didn't use the anterior approach at all, and through a fibular strut, achieved a solid fusion in his 11 skeletally mature patients. It's a technique that's still used today, particularly by his fellows. And he had excellent resolution of symptoms and significant and complete improvement in symptoms. But again, not being able to address the spinal-pelvic relationship. Weinstein also reported in long-term follow-up of patients with grade 3 and grade 4 spondy, with and without posterior fusion. And again, he found 18 years later that in those who were non-operatively treated, they remained asymptomatic in an average of 18 years. And those who were treated operatively had the problems. In situ fusions, in bilateral posterolateral fusions, decompress as needed, success rate 60 to 100%, and addition of pedicular fixation improved the fusion rate, but did not necessarily improve the outcome. And then molar studies, that was a prospective randomized study, 77 patients, no difference in functional outcome or fusion rate when you compared the two groups. And then interbody fusions for back pain and Ken and Lopez, that what they found was you address the pain component, the degenerative disc disease. It's a good salvage procedure for failed posterolateral fusion, and that the structural graft restored disc height gave you indirect foraminal decompression, restored foraminal alignment, reduced the risk of progression of slip, and fusion rates were anywhere between 73 and 100%. So by accessing the anterior column, I think you can certainly achieve that. Combined anterior and posterior, Wong reported in 1996, 21 patients, 2-year follow-up, 95% clinical success, 95% fusion. So what we see from the studies that are commonly quoted, it's pretty much all over the place, right? So where are we with all this stuff? And really, NASS addressed this through this evidence-based clinical guidelines for multidisciplinary spine care, right? So they put this group together to look at the evidence-based clinical guidelines as far as diagnosis and treatment of adult, isthmic spondylolisthesis. Is there evidence to support these issues? So what they did was they first identified the group and then identified commonly posed questions, and can we answer those questions with this evidence-based guidelines that are available today? And here are the levels of evidence. If there's good evidence, it was level 1 studies with consistent findings for against the recommended intervention. Fair, level 2 or 3, poor quality, level 4 or 5, and then I for insufficient or conflicting evidence. And so here's what they came up with for the commonly posed questions. And we can't look at all of these, but what we can see is for adult patients, what symptoms do they commonly present with? It's low back pain plus or minus leg pain, and there's pretty good support for that. In adult patients, what is the relationship between the radiological grade and the expected clinical presentation? Very little evidence to support that. Inconsistent. What is the role of manipulation? No evidence for that. And then other conservative modalities, no supportive or inconsistent evidence for that. Does the degree of radiological grade and sagittal spinal pelvic alignment, do they matter? And there's inconsistent evidence to support that. Does the addition of a lumbar fusion, or with or without instrumentation, in addition to surgical decompression, improve surgical outcomes? And there is no evidence to address this clinical question, and therefore the paucity of literature addressing this question. Here's the most important question, and yet we don't have the evidence to support that. Now, for my talk, how do outcomes of decompression with posterolateral fusion or 360 influence outcomes? What we know is this: posterolateral fusion and 360 fusion surgeries are recommended to improve the clinical outcomes in adult patients with low-grade isthmic spondylolisthesis. For low-grade, it's there, and there's good evidence for that. 360 fusion is recommended to provide higher radiologic fusion rates compared to posterolateral fusion, and there's good evidence for that. However, there's conflicting evidence of whether 360 fusion provides better clinical outcomes to posterolateral fusions. So there's conflicting evidence for that. And what is the role of standalone? And something that I like to use, especially in degenerative spondylolisthesis, it's not part of this talk. So when can you use it standalone? In low grade, grade 1 or less, may be considered as an option to indirectly decompress the foramen. Again, you rarely see central stenosis with lytic listhesis in adults unless it's high grade. But in low grade, it's usually the foraminal stenosis that we have to deal with. And you can best address that with an anterior approach and indirect decompression. And there's good evidence that a standalone Alif will work there. And how do outcomes of dynamic stabilization compare with fusion and I address that there's nothing to support dynamic stabilization from the posterior aspect in addressing this question. And then does the addition of fusion level Sevlat or Kodat, so if you say, well, I have a higher grade, or maybe I'm just going to add L4-5, that's going to get me a better fusion rate. Well, there's no evidence to support that question either. And then a couple more are the results of surgical management for adult patients with Isthmic Spondylolisthesis affected by the presence of scoliosis, and very little or no evidence to support that question. And is the surgical treatment of Isthmic Spondylolisthesis cost-effective compared to medical and interventional therapies? And there's no evidence to support that. So I'm just highlighting some of the very common questions that we ask ourselves as professionals in dealing with this. And there's, you need to look at this so you could be honest with your patients and honest with yourself as to what you can expect as far as outcomes are concerned when dealing with this. So in summary, there's paucity of high-quality studies regarding appropriate management of isthmic spondylolisthesis in adults. Evidence seems to support fusions for successful outcomes. 360 is best in achieving a fusion, but we still don't know whether that affects long-term outcomes in patients. Evidence-based recommendations are limited, and there's a clear need for well-designed, high-quality studies in this area answering these specific questions. Thank you.
Well, that's a very nice talk. I agree, it's a very nebulous area as to what to do. Anterior surgery for high-grade spondylolistheses, I have found that to be exceptionally difficult to get a cage in the front, to get over the pelvic brim and everything. I'm caught anyway. How do you address those? I mean, those are usually somebody I would do Tlif on, and you know, with reduction screws and loosening things and paddles and sacral dome osteotomies and whatnot, you can get a pretty fair reduction, them back to like 50% and not damage the nerve roots and everything. So generally for a grade 3 or 4 in particular, I would do something anteriorly, or not do anything anteriorly because it's very difficult to get to the disc space.
Yeah, and those are all excellent points. And having said that, I'll tell you, I've lived through the Chuck Edwards fiasco where we reduced spondies in adults. And what I found, I mean, we had almost 100% L5 nerve root injuries in that study. That's kind of why a lot of them didn't get published. And what got published, I really was really jaded because what I saw in my center was almost every single one of them had a L5 nerve root injury. And so I'm very careful as to what I do in adults. What I look at doing in adults when I've got a high-grade spondy is reducing the slip angle. If I can reduce it, I'm super happy.
Sure. Yeah.
So that's number one. So that's my reduction as far as my reduction goes in adults. Addressing it from the front, I think you still can. I think you still have the same problems going at it from the back as you do from the front. But from the front, what then I would do is kind of a reverse Bowman, where I would do a fibular strut through the disc space from the anterior aspect. I think putting them supine on the table, you'll get some reduction. I think furthermore, to visualize the disc, I will take down the inferior aspect of the vertebral body. Yeah. And then that way I can see the disc space. And then what John Cosworth taught us is to do a fibular strut from the front as opposed from the back. So that's what I would do, because you're not left with much disc space to deal with. So really, to try and put an intervertebral device, that's going to be super hard.
Yeah, well, a lot of the studies that you were kind of quoting there, they were done before we had all these marvelous Tlif instruments that we can do bilateral, elevating of the disc space. And if they've got a vacuum sign, you're made in the shade because it's mobile. So there's odds pretty good you're going to be able to put, something like black bullet dilators from both sides, or use a concentric one, whatever you want to do. And just as you elevate the disc space, it cantilevers back naturally. And at the same time, you're not particularly stretching the nerve root. So it's kind of rare, I think, nowadays to get a nerve root injury like in the past where they just try to muscle it back. And so I think that for me, we do a lot of these, and the higher grade ones, I mean, if they're real high grade, you just do a corpectomy, do a gauge procedure, which is really fun. Yeah. But I think a lot of times I never can get the cage to go in. And yeah, that the procedure, the fibular strut, that's actually in the first edition of Campbell's Orthopedics. It was first done in the 30s, where they take a live fibula and pound it across there. So that's been around for a long, long, long time.
And
it's a good procedure. I mean,
it still works. I did one last year, and it still works.
But one of the things that Rousselet has shown, if you can reduce it from a grade 4 to a grade 2, which is certainly feasible with modern Tlif technology, it realigns the entire global spinal balance all the way across the transition zone, and gets the whole body, particularly the type 6 ones that are decompensated. It brings the entire superstructure back over the center of the sacrum, and the whole spine realigns. And I think long term that gets better fusion, and probably is, because I've seen some of the ones that were fused by my predecessors with just in situ fusion, the Wiltse procedure, and they come back in their 50s with pretty severe adjacent degeneration.
So John, I'm going to reverse ask you a question, because I have trouble sometimes, and innocently in the past, I would just say spondy, pain, fuse. And that's just not true. And so I try and search the pain generator a little bit better, a little bit more.
Sure.
And, from that Toronto paper, I looked at the L4-5 level a little bit more, because the disc is not loaded at L5-S1 and lytic spondy, right? And neither are the facets. So where are the pain coming from? And what am I going to do on this big operation on a patient, right? If I can't give them a reasonable chance of an outcome, because I haven't done my job as identifying the pain source. So what do?
You mean like a high grade, whether it's coming from the high grade?
Low grade, high grade, like how do you identify the pain source today?
I think the number one indication for me to do surgery would be nerve compression, radiculopathy.
Yeah.
And a lot of times these higher grade ones, they'll come in with, particularly the younger patients, because they're going to be in the less sub 16 or 18-year-old. It's when most of those high grades seem to come in hot. They come in with heart-shaped buttocks and contracted hamstrings, and they walk like they're on stilts. They got leg pain. You can't do a straight leg raise on them. So they have, mainly nerve root signs. And to me, that's the real indication for surgery. Now, with the degenerative spondy, that's a little bit different story.
Yeah, that's different.
Because some of those patients have back pain, but, there I would be very hesitant to operate on them unless I saw that they had gross instability when I flexion stented them or put them in an MRI, whatever you want to do. Or they had radicular symptoms. And radicular symptoms, again, for 4-5s are probably my number one indication for surgery, failing, conservative treatment.
So right, and I'll tell you, as I've gotten older and later in my career, and listening to my mentors, and I was lucky to be with Edwards and Costwick and Bradford and you and others, and everyone at the end of their careers, and happily you're not, but have all said, I think we've done too much. And that's led me to get more and more. Here I am. I've been taught to crack necks and do simultaneous front backs and to do osteotomies everywhere. And these guys are telling me maybe we've done too much. So I've gotten a little more conservative in a number of ways. And So in the spondies, I talked about it quickly, but if somebody has a pure radicular pain and has a grade 1 to do spondy, would you ever dare to do just a limited foraminotomy at L5S1?
And that's exactly what the Swedish study showed, is that they just would do nodal fusion and foraminotomies on stable, less than 7-degree spondylolistheses, degenerative ones. They did okay.
And what about 5-1?
Well, they didn't address 5-1. They addressed 4-5s. And they found that if they fused them, they got adjacent nodal degeneration quicker. If they didn't fuse them, they were more likely to have a later follow-up fusion. So it's kind of yin-yang, damned if you do, damned if you don't. So there's different outcomes for each one of the procedures, but there are times, I know some of my junior partners that are really good at decompressions, they've done stable, gnarly 4-5s that don't move, and they've done great with just a decompression. But they usually come back.
Right, but what about 5-1? Would you do a 5-1?
Well, I think with stable 5-1s, with mainly a radicular leg pain, we will do a selective foraminotomy on them.
Yeah.
Because it doesn't matter. That's not, if you take out the facet joint, it's not working anyway, right? It's providing no stability.
I just did one on a plastic surgeon best friend of mine, and I'm just watching him very carefully.
Are you sweating?
I am very much. But he was looking at a 4-5-5-1 front back, and the guy's super active, so I holding my breath.
Great talk. For the high-grade 5-1 slips, can you just talk about what the extent of the construct might be? What is the extent of the construct that you would use for a high-grade 5-1 spondy or a spondyloptosis? Do you commit to a L4 to pelvis, or what exactly?
Right. So that's where I do. Well, first of all, you do a full scoliosis series, right? And I think you're going to have to go higher than 5-1, obviously. If anything, and that's what Chuck Edwards taught me a long time ago, you need to get that cantilever because there's high tension at the L5S1 level. So you're going to need to go at least 1 and sometimes even 2 levels. So, and I think to get that stress relief on L5S1 construct, you're going to have to do that, right? So the ones that I was talking about doing a fibular strut, you're going to pierce at the top of the 4, at the top of 5, probably violate the 4-5 disc. So for sure, I'm going to get 4-5 and 5-1 involved. But if I see that sometimes 3-4, if there's an abnormality at 3-4, I may have to go up one step higher then. But it's usually on these high grades that John was talking about, it's at least 4-5 and 5-1. John?
Yeah, I agree 100% because the L5 on a true high grade, one that developed when they were young, the TP on 5 is hypoplastic.
Right.
And the one on 4 is hypertrophic. So it's like 1.5 inches long. So it's a great, those muscles are like a bowstring. Clearly that's what's supporting the L5 is out of the picture now in front of the Wickering line.
Yeah.
So, sorry. I was just saying that the L5 transfer process on a true pediatric developed spondylolisthesis of grade 4, 3 or 4, the TP is always hypoplastic, no place to fuse. So you got to do an interbody fusion, or you've got to jump up to L4 where you've got a big hypertrophic L4 process. So that's what most people would do, Yeah.
Right.
So thanks so much, JJ. We're going to transition